Welcome. Thank you for joining us today. My name is Amy Sam. I am the Health Education Project Specialist at the Maxwell and Eleanor Blum Patient Family Learning Center at Mass General. Before we get started, I just want to go over the items with you all. Please note that today's session is being recorded for educational purposes. If you're interested in viewing the recording, you may visit the Blum Center website at massgeneral.org/Blum-Center. Please note that you are in listen-only mode. Everyone has been muted so we can hear our guest speaker today. If you have any questions for our guest speaker, you may use the chat feature, which is located at the bottom of your screen. We'll have time for in the end. Only Blum Center staff and our guest speaker will see your questions. Please do not share any personal medical information or questions in the chat. If you have a personal medical question, please ask your doctor. Lastly, at the end of today's session, you'll be directed to a brief survey, which we would like to ask you to help us complete. Your feedback is important to us as we plan future programs. So next, I would like to introduce you all today's guest speaker. Joining us today, we have Joel Lee. Joel is a physician assistant in the Department of Urology at Mass General. His mission with patients is to provide extraordinary care in all interactions by fostering an environment of trust, education, and empathy. Joel has spent the last 5 years specializing in neurourology and the aging lower urinary tract. He joins us today to give a talk on aging in the lower urinary tract in females. So please join me in welcoming Joel.
Great. Thank you so much, Amy, for that introduction, and very nice to connect with you all today. I'm going to share my slideshow, just my presentation, so just a moment. All right, perfect. So today's topic will be about aging and the lower urinary tract in females. Today's presentation will consist of 4 different sections, just noticeable breaks, where we'll first talk about how aging affects the lower urinary tract for everyone, what to expect during a visit with urology, and then 2 specific topics. First on urinary incontinence, or the definition of leaking urine, and the second of urinary tract infections and pelvic pain. So in our first section on how aging affects the lower urinary tract for everyone, we'll just first start by a little bit of anatomy, very brief anatomy. So first we talk about the genitourinary system. And this is just an appreciation for how all the structures of the genitourinary system are close together, both males on the left side and females on the right side. And then in terms of speaking of the lower urinary tract, we want to reference to the upper urinary tract as well. And so the urinary tract is this whole system here, and the upper urinary tract specifically refers to the kidneys and ureters, and then the lower urinary tract refers to the bladder and urethra. Here's just a closer view in terms of the bladder. We see that the bladder is a vessel with a thick muscular layer called the detrusor muscle. The 2 ureters, one from each of the kidneys, drain into the bladder, and the urethra is the outlet, and sort of the inlet and outlet form this triangular area called the trigone. And additionally, too, we recognize that the lower urinary tract is a complex communication pathway with the bladder, brain, and spinal cord, where sensation and input from the bladder goes up into the brain, and then the brain sends it down the spinal cord back into the bladder. And as a result of that function, we see that the bladder has 2 main purposes. The first is that 99% of the time it is spent filling up. We call this the storage phase. And the other 1% of the time is spent emptying, called the voiding phase. And one last difference is just thinking about how the bladder anatomy, or the lower urinary tract anatomy, is slightly different between females and males. Whereas males have a prostate and 2 sphincters, the females only have one sphincter and use the pelvic floor as well for controlling symptoms, for controlling emptying. And that's why incontinence later on will be such an important topic. So the question is, what is aging? Well, we recognize that it is a large population, that 16.5% of the US population in 2019 are 65 or older. And then additionally to aging consists of a population that have increasing disability, where we just see the stat from the NHATS, where 20% of adults in the age range of 65 to 69 have a disability, and that increases to 80% by the age of 90. And then secondarily, we see that a vulnerable population where adults in the ages of 60 and older live alone and they're isolated. Furthermore, aging includes predictable changes to the body, increased body fat, decrease in brain size, reduced ability to sleep deeply, and these other ones as well. And then finally, we just recognize that aging, there's no normal to compare to. The lower urinary tract really doesn't have very limited ways of telling us symptoms. And so as we get older, we find that the difference between two people who might be reporting the exact same symptoms might have two completely different issues. And thus we have tools to help discern the diagnosis that we'll go into later as well. And we also think about relationships of aging and the lower urinary tract. In the context of aging, first we recognize that people who get older are at risk for falls. And certainly with fall risks, any rushing to the bathroom or waking up at night, we just worry about what is the risk of falls and how the urinary symptoms might impact that. And secondarily, too, is isolation. Just a stat mentioned earlier is that as we get older, we're more vulnerable and at risk for becoming isolated. And certainly symptoms like urinary incontinence or feeling like you need to stay close to the bathroom regularly can just be further isolating as well and just further isolates each individual. The other part too is as we get older, there are different diseases that we come across. We recognize again of just the communication pathway of the brain spinal cord, as well as the upper urinary tract, that different diseases that impact this will certainly impact our lower urinary tract function. Any process that affects any part of this, for example, diabetes, any neurologic diagnosis like dementia or stroke, peripheral edema, severe constipation, all of these associated with aging can greatly impact urinary tract function as well. And the next piece too is that we have to think about how the lower urinary tract itself ages. That as we get older, there are the age-associated changes. One is there's changes to how the muscle acts and functions, that thick muscle layer that we saw in the initial picture. And then we also see urogenital atrophy, just meaning that the tissue does break down and thin out. Additionally, too, when we think about the aging lower urinary tract, we also think about the surrounding conditions that may impact the lower urinary tract, how limited mobility and or dexterity. We think again about isolation, caregiver and social support, sleep pattern changes and medications can greatly impact how our lower urinary tract functions. And then the final piece of just the relationship of aging and the lower urinary tract, we specifically think about life events of females. Well, certainly I've listed out 3: childbirth, menopause, and undergoing a hysterectomy. There's plenty of women who undergo these or have these life events and may not have symptoms, but certainly we know that these parts can contribute and increase the risk of symptoms forming. So in summary, the lower urinary tract consists of the bladder and urethra. The bladder function is very complex, requiring communication with the brain and spinal cord. And the female lower urinary tract has only one sphincter mechanism compared to the 2 in males. And aging impacts the lower urinary tract from a variety of issues of increased risk of falls, disability, social isolation, progressive changes of body, and development of age-associated diseases that directly impact the lower urinary tract function. So that concludes the first section of how aging affects the lower urinary tract for everyone. Now in our second section, where we want to share what to expect during a visit with urology. When would you see urogynecology, a subspecialty of urology, or urology itself? And that's certainly depending on your symptoms, following a very thoughtful conversation and evaluation by your primary care physician. What's very important as we prepare and as you prepare for any visit with a specialty, but specifically in urology and urogynecology, is that there's bits of information of just making that first visit really impactful and really helpful for both the clinician and also thinking about your goals and how your symptoms might be improved upon. The first is a 3-day voiding diary, which is just a careful, detailed recording of your symptoms, which I'll go in the next slide. But also we want to make sure that you gather all your lab tests and imaging results. And then we consider and really recommend that you consider thinking about when your symptoms started, going as far back as possible, back to your childhood. And then also being aware of your medications or medication lists. If you're caregiving for someone else, sometimes it's called a brown bag, where you just say, bring all your medications so we can take a look and see what might be impacting the lower urinary tract function. This slide here is the 3-day voiding diary, where it's just simply a very detailed log, where at every moment you think about the intake and the output. For the intake, just anytime you drink something, you just write down what it is and how much you drink. And that's that second column. The third column, we ask you to record your urinations, specifically the time of when you urinate. And if you have some measuring device, some urinal, disposable urinal, you can measure volume. And then if for some people who use catheters, recording those volumes down. And for the last two columns is thinking about for people who do suffer from incontinence, where we want to know when does leaking occur, and then whether or not any incontinence supplies, such as with pads, were used, and when they were changed and how much was affected. So in the first visit, when you come into our office, the first thing is we certainly always recommend people to come in with full bladder, where we'll collect a urine sample. And this really just tests the chemistry of what might be the contents of the urine. And then another test is called a urine flow. So this is just the device here that you see on the left, where there'll be a seat that's seated over it. And essentially, instead of urinating in the toilet, you urinate into this device. And it measures based on weight how quickly or how fast the urine flows out. And a product of that is, you see on the right side, the graph, just what a natural graph of a normal flow would look like. It's a near parabolic curve, where as you start, you go quickly, and then once you're done, nearly empty, you just empty pretty quickly. And that's what we would want from a normal flow. And then the third part is seeing the leftover urine in the bladder. So specifically, we look at the suprapubic region. That's where the bladder sits underneath, where we have a bladder scanner machine and can really just assess how much volume is left over. So we can see what is the ability of the bladder to empty itself. Now, in part of history, again, just making an emphasis that it'll be a very extensive discussion. The work that you put in is really the part where we'll just really want to comprehend and understand as a clinician. The diary, any testing, your symptoms dating back to childhood, and any medications. And then another part too of the visit will be the physical examination, where part of it we'll just use that as landmarks. This is just landmark of the female torso, where if we think about the structures underneath, the kidneys and the upper tract, and then the bladder and urethra and the lower urinary tract, we really consider and think about your symptoms. For most issues where testing alone will be sufficient, often vitals and general appearance will be fine. But when would we do further examination? Well, for indications to examine the torso, it's whenever you have any flank or lower abdominal pain, where we say, is the lower urinary tract involved, or even the upper urinary tract involved with this? So the X's mark in the lower for the suprapubic area, where we might palpate that area and just see how distended it is, how full it is, how tender it might be. And then in the flanks on the upper back, that's where the kidneys lie, we evaluate for pain there. And certainly just to make sure we understand, can we precipitate your symptoms more to understand what's going on? The other part is, at times there's an indication to examine the pelvis. Certainly if there's any level of pelvic pain or symptoms of pelvic organ prolapse, that is, if you look on the right side picture, you just see where the bladder, the female reproductive organs, and the rectum all really sit close to each other. And so pelvic organ prolapses, whenever any of the ligaments or support structures start to weaken, sometimes they can go into the vaginal canal, and the anatomy of those other structures can be visible there. So if any times there's a sensation of a bulge, or even if you notice during just self-examination that something doesn't quite look right, there's certainly a concern for prolapse that's there. And that can be associated with pain, and as well as changes in urinary symptoms. And depending on what other organs might be there too, certainly other symptoms that will be involved with the specific organ that's prolapsed. That's the right picture. The left side too is thinking about pelvic pain. Often you see this interconnected network of muscles, where if there's any issues or tightness of muscles, that can be contributing to pain. And therefore, the pelvic exam, to examine and isolate each of the muscles to see how it looks, and see if we can precipitate the pain can help us give us more information on how we might be able to help. And so with recommendations following the in-office testing, the history, and the physical examination, there's just some different approaches depending on what has been discussed, depending on truly on what your goals are, where we can approach things more conservatively, or if things seem really complex, we can do more testing as well. Very briefly, for lifestyle modifications, here are just some few examples of what that might be. Certainly one is to stay well hydrated, where we've just really found, especially in the realm of urinary tract infections, that males and females, actually study has been done for females that drink about 2 to 2.5 liters of water, can really reduce the risk of urinary tract infections. We also want to recommend minimizing drinks that may dehydrate you. Certainly coffee, we know that coffee, tea, and alcohol can increase sort of the kidney function and stress the kidneys to pull water from your body and dump it into your bladder. And more fluid in your bladder might be manifesting as worsening symptoms. And then also the other part too is another recommendation might be emptying your bladder at regular intervals of time, where we would say, try to empty your bladder every 2 or 3 hours, because certainly we don't want that bladder to be really stretched out, because the more often it gets stretched out, the weaker it can become. And that itself can impact symptoms as well. And then your habits before bedtime and with nighttime symptoms, what you eat and drink and sort of what your activities are before bedtime can really impact of how often you're going to the bathroom at night. So that's just some examples there. There's a few others as well too, which we'll specify for incontinence and urinary tract infections later, but just a brief overview of what that conversation might look like. The other part too is, as I talk about medications, is just any recommendations about any recommendations for lifestyle medications. We just know, studies have shown us that it takes about 8 to 12 weeks to really see any difference and seeing how what changes have happened. Sometimes we might even ask for a repeat of that 3-day voiding diary, so we can really track the symptoms of how things were before you came in and afterwards, how after these changes were made. Now, for a very brief overview for medications, there's certainly a number of them, but just principles is that sometimes the symptoms and the testing will show that the bladder is being overly sensitive and emptying too much. There's some issue with the storage. And therefore, there are a class or list of different medications that might be able to just calm down this hypersensitivity to help you feel like you have better control and you don't need to rush to the bathroom so often. At other times, there are reports or examination that the bladder is really struggling to empty itself, and it just needs help in emptying more. And there's just these other classes of medications to help you empty and urinate better. And then the final part of this section is just thinking about specialty testing. Why specifically urology might be able to see and evaluate more what's going on. There are 2 particular tests that I will highlight. The one is called the urodynamic study, and the second one is called cystoscopy. With the urodynamic study, there's just a very brief cartoon of what it might look like, where the test is just with you sitting in a chair, where we really evaluate the physics of the lower urinary tract function. We look at pressure, we look at volume, we look at flow, and we look at resistance. And sort of with the setup of the urodynamic study, you see on the right picture that how we achieve this is that we have different sensors and pressure sensors and different leads checking on electrical activity to look at that lower urinary tract function. One will be going right into the bladder, where we examine, where we'll be able to fill up the bladder directly and also sense that bladder pressure. We'll also want to examine the abdominal pressure. So there's that second sensor going to the rectum. Whenever there's any issues of, especially for females, if there's any issues of placing anything in the rectum, alternatively, we can place it in the vaginal tract as well to measure abdominal pressures. And then finally, there's just some electrical patches or electromyography patches that will just evaluate the pelvic floor muscular electrical signals. So if you look on these charts on the right, just in brief of what the urodynamic study graph looks like, is that one is as we fill up, we just expect this linear part of filling your bladder slowly till it reaches a full point, and then you'll be commanded to urinate. Again, just right where you're seated, all of this will take place. We look at the bladder pressures, and then we're able to specifically measure the bladder pressure without abdominal input. That's that that middle row. The fourth row is just the abdominal pressures, that sensor going to the rectum. And then the final part is thinking about the flow. So as you're attempting to urinate, we can really coordinate or think about how pressures relate to the flow as well. The test itself is about 15 or 20 minutes, where we really examine sensation, what is felt during the study. We think about the stress, adding abdominal pressure with coughing or engaging your pelvic floor muscles. We think about bladder response, the pressure of the bladder while it is filling, and bladder function as it's time to go. We see what pressure is generated while you empty. And for some specialty, even more specialized testing, sometimes we can have an X-ray machine, it's called a C-arm, where it just wraps around that chair, and we'll be able to take some images of the bladder outline and just give us some further insight as to how the lower urinary tract might be manifesting itself as symptoms. The other test is called the cystoscopy, and this is a very brief slide where imaging helps us look on the outside, like the outside, or gives us some little idea of what the interior aspects of the bladder look like. But the way that we really can evaluate the lower urinary tract anatomy from the inside is with this flexible camera, a fiber optic camera. We can really do a full surveillance of the urethra and the bladder itself. And particularly this is indicated when they're very specific indications initially is if there's like any abnormal bleeding when you urinate, that's outside of a urinary tract infection, or if there's very marked pain, or if there's any images that say, there's something that needs to be looked further. That's where the cystoscope will be very helpful. So a summary of this section is at-home preparation is very key. The work you put in and thinking about your story will just really help that conversation and the recommendations moving forward. And then we want to know during that first visit, it can mostly be a conversation, especially if there's none of the indications for the abdominal or pelvic exam, of just knowing how you and your health is related to your lower urinary tract symptoms. Again, the physical exam is probably just very general typically, unless there's a very specific indication. Initial recommendations are often lifestyle changes and consideration for medications, or if things just seem very complex, by the clinical recommendation, there might be more testing with the urodynamic study or cystoscopy. So that concludes the second section, what to expect during a visit with urology. Now we want to go into the next two sections, really thinking about specific cases that really can impact the female population. This third section is on urinary incontinence, or just leaking urine. And so you'll see the definition is urinary incontinence is when uncontrolled leaking of urine happens when intending to stay dry. And we wonder, how is the urinary incontinence affected by aging for females? Well, it kind of goes back to what was discussed earlier, is that anything impacting both the lower urinary tract, the upper urinary tract, and the communications with the spinal cord and brain can really be a major factor as to why urinary incontinence manifests itself. And so just these two previous graphics that were shared before is that sometimes the bladder is really struggling because it's not too sensitive or not sensitive enough. And sometimes the bladder is too weak, or there's some outlet issue on the right. And any of these processes can really impact any of that. And as a result, downstream, where the bladder is really, really struggling, we see incontinence be an issue and appear itself. And we recognize too that the cost of urinary incontinence is very high. First, even just from a numbers standpoint, we just see in society that in 2011, so this is from a study from 12 years ago, that $12 billion was spent in the US for management of incontinence, whereas 9.8 billion was just spent on breast cancer, just anecdotally, of just the price comparison on managing incontinence. And we know too, just several population studies have shown that really a significant portion of females, 1 out of 3 over the age of 40, are affected by urinary incontinence. And as we think about the symptoms specific to the individual, we see that it really can impact relationships. First is social engagements. Like for people who are leaking urine or feeling like they're tied to a bathroom, often they limit how often they go out, going to parties or restaurants or seeing friends, just simply because they're embarrassed by their symptoms. The other part too is that physical activity can be limited, where different motions or different movements or certain precipitating factors will cause these very bothersome symptoms. And so people will try to manage by reducing what they do. And for sexual intimacy between partners, is that if there's leaking that does occur during sexual intimacy, that can be very embarrassing. And so that can lead to a marked reduction or abstinence from sexual intimacy. And then just practically speaking, is thinking about the individual financial burden. It's very unfortunate that for the very population that we're really interested and focused on, speaking about the population of 65 and older, that most incontinence supplies are not covered by insurance. So there's a high individual cost. And just this was a very brief search. I just went on a wholesale website on Costco and saw that for a pack of 68 to 92 adult briefs, depending on the size, is $41. And for pads, it's $35 for a pack of 108. And if you have to use multiple pads or briefs or some combination of both, that just ends up being a major part of your monthly expenses. So when we think about incontinence, actually, there's the definition, very, very simple definition of leaking urine when not intending to. But we recognize that incontinence has sort of different manifestations. And we want to go over 3 very common ones and also provide sort of what is happening, an explanation of what is happening. That's part of why I went into a little more explanation detail of the urodynamic study, is just to get some understanding of what that test is of the lower urinary tract physics. So I'll be using this as we explain each of the different types of incontinence. First is the stressed pelvis. So this is a normal urodynamic tracing, and then I'll just overlay little text just to show what changes occur. So for the stressed pelvis, we see that the resistance in the female anatomy for the one sphincter mechanism in the pelvic floor muscles cannot prevent any leaking when there's increased abdominal pressure. So that's with coughing, laughing, or bending over. And we see on the urodynamic study that the results are, as the abdominal pressure, the bladder pressure is not changing, but just an outside exertion by the abdomen, excuse me, and any part that puts more pressure on there will lead to a leak. And that's typically caused by changes to the pelvic anatomy. We see that for females who have given birth to especially multiple children, that there's almost a 2-fold factor increase of risk of forming incontinence because of just a stretched out pelvic floor muscles. The resistance has lessened, or in terms of the weakening of the ligaments or support structures that are there. Additional too is any pelvic trauma or surgery can also contribute to stress urinary incontinence. That's why for male counterparts, because the prostate is involved in helping men remain dry, when you remove that, that increases the risk of men who become to leak. It's the same principle of reducing that resistance so that abdominal exertion will lead to the incontinence. The next one is the spasming bladder. So with this overlay, there's this term called urgency urinary incontinence. That's where the bladder, as it is being filled up, the bladder itself suddenly generates this very large pressure that is so strong that it makes it difficult to hold urine. That's the story where you say, I was shopping or I was going about, within 1 minute, I had to get to the bathroom. Otherwise, it just started leaking out. That's possibly because the bladder is just generating this strong contraction that makes it too difficult, and you have a very limited warning time to get to the bathroom. And this part here, the urgency urinary incontinence, with the urodynamic findings of, we use this term called detrusor overactivity, may be caused by various disease processes impacting the way the brain, spinal cord, and bladder communicate. Just that neural pathway of the interplay of those 3 parts, the central nervous system of the brain and spinal cord plus the bladder, can really impact the way in which the bladder senses and responds as well. This can also impact this 3rd part, the weak bladder. So the same reasons that can occur for the spasming bladder can also occur for the weak bladder. And in this case, I highlighted one manifestation of incontinence called post-voiding incontinence, where essentially the bladder is too weak to fully empty itself when it's time to go. The bladder may not be strong enough, and so there will be just large volumes of urine left over, even when you apply abdominal pressure. So you see that the bladder pressure itself is blunted, and therefore the flow rate is blunted on the left side, and sometimes people will exert a large abdominal pressure to try to empty itself and still not be able to empty fully. And so certainly what was said before about processes impacting brain, spinal cord, and bladder hold very much true here as well. But another part is sometimes the bladder, especially there's this very fancy term, but essentially it's called dysfunctional elimination syndrome. But what that simply means is that since childhood, along the way, there was some interval of years was just routine daily occurrences where the bladder was just allowed to just fill up, fill up, fill up, fill up, fill up, and just gradually stretch over time, so that eventually it became such a large vessel that the bladder muscle itself became weaker and weaker. And so these are just three manifestations. This chart lists here is just to really appreciate. I highlighted three of the more common ones and sort of the more straightforward urodynamic diagnoses, but there's certainly other ones here. And sort of even if you caught one or two of these lines, there's just multiple, probably different processes, both of the lower urinary tract and maybe even outside of the urinary tract, that might be contributing to incontinence. So we certainly just stand back and are humbled a little bit by the complexity of the manifestations of incontinence, even though, again, it can just be leaking urine when not intending to, but the reasons why can be very vast. And in terms of management of urinary incontinence, we've actually found that lifestyle, a balanced diet, good fluid intake, regular exercise is one of the, it seems very straightforward, and this is like, well, isn't this true for all health? But we've actually had studies showing that when people eat well, sleep well, exercise regularly, drink good fluids, that a lot of their incontinence symptoms can greatly reduce. So we're just on the bandwagon to say eating well and exercising regularly is very important. And this last line here is about Kegel exercises. This is a very common exercise that's recommended to females, especially for those who have given birth. That if you just tighten, when you urinate and you just try hold your muscles tightly to hold the flow, maybe that might strengthen the pelvic muscles and therefore reduce incontinence. And this is really only good for if stress urinary incontinence has been proven. If there's other manifestations of urinary incontinence, especially I would highlight the weakened bladder, the Kegel exercises increase resistance and will just further stress out the bladder as well. So really, we only recommend it when it's been truly, when there's just the true indication of stress incontinence. And finally, it's just, the other part is just functional management, where I just want to go over a few incontinence products, just in terminology. There's protective underwear, pull-ups, pull-on pads, adult briefs and diapers, incontinence pads and liners, under pads and bed pads that you just put on bed when you sleep, and even commodes. Some people just have a bedside commode when they don't feel like they can get to the bathroom in time. And then specifically a product that's may be very useful for females in particular, especially when the primary manifestation is leaking at nighttime, is called the female external catheter. And sort of this is three images of what that device is. This is a specific product called the PureWick, but there are a couple other devices out there similarly, which is this, you have this wand, the PureWick wand, which has an absorbent pad that is connected, that's the top left, that is connected to a vacuum suction device, very light vacuuming, so that whenever there's any bit of leaking, the urine will be sucked into and just collected in the container, as opposed to leaking into the clothes, pads, or the bed. And then just in terms of the right picture is just the placement itself. So this, for some people who find that nighttime symptoms are particularly bothersome and feel that they could tolerate a placement of this device, just in this particular location, and feel like they don't move around too much in sleep, because if you move and shift, then the device might fall out. This might be something that is very helpful. And then just very 30,000 feet overview of what specialty recommendations is that there's some combination of medications and office treatments and surgical management that can be considered, but it really boils down to your story. Like, what are your symptoms and goals, your medical history, the physical examination and its finding, and any specialty testing findings, like with the urodynamic study or cystoscopy, or together, sort of there's this collaborative approach with the clinician and the patient to really think about what truly would be the best option depending on the outcomes that you're trying to reach. So in summary, the urinary incontinence can be very distressing, affecting many people and their livelihood. There are different ways that urinary incontinence can manifest itself. Simple lifestyle changes of having good balanced diet, regular exercise, and good fluid intake can really improve symptoms. It's just been shown. And then there's different products and recommendations just based, again, on your goals. So that concludes the third section. And now just with the fourth section is an overview of urinary tract infections and pelvic pain. Trying to tackle the nuances of both is certainly, it's very nuanced, I would say. So this part here is really just helping us think about how does urology approach urinary tract infections and pelvic pain. So with definitions, urinary tract infections are worsening lower urinary tract symptoms. Typically, there'll be urine tests showing that there's bacterial growth and sometimes inflammatory changes. And then chronic pelvic pain is the occurrence of persistent or recurrent episodes of pelvic pain. Sometimes it's just ongoing, and sometimes it's just these bouts that seem a little bit cyclical and typically should be absent of infection. When speaking of urinary tract infections, we really want to first bust a myth. This is something that is a common, conversation or counseling point in urology, which is, someone would come to us and say, "How did I introduce this bacteria? Where did it come from? Isn't E. coli from the bowels? Did I do something wrong?" It really puts the onus on the patient, where that's just what we've just really found is that's just not true. The myth is that the bladder, it previously thought was a very sterile environment, is really not a sterile environment. Should you ever develop even one infection or any way that bacteria is introduced, the bacteria will just burrow themselves into the bladder wall tissue, build a roof over our head, a very impenetrable roof to antibiotics over the head called the biofilm, and they can just stick around. Even the most strongest antibiotics would not be able to fully neutralize the bacteria that's there. Just an example is that there's been one study showing that if you took a bladder biopsy, you would see 80 billion. So any one of us, if you took a biopsy, and this is not a routine thing, but just what we understand is that if you took a biopsy and looked at tissue really closely under a microscope, you could count up to 80 billion colonies with this biofilm matrix that's just hanging out there. And then we also know that bacteria are single cell and can mutate easily. So they've survived just for many, many more years, probably more than humans, and they've survived much harsher environments than our bladder as well. So it's not about introducing, it's about the bacteria that's there and how we think about thoughtfully how they become symptoms as an infection. So with the diagnosis, often, we get a urine sample and then we'll culture it and see what type of bacteria grew out when there are symptoms, and sometimes there's something there. And that will help kind of lead us into knowing that, a urinary tract infection is a diagnosis. But on the flip side, when we think about aging, especially the topic of our conversation, is that as we get older, there's often this thing called asymptomatic bacteriuria. I'll say that again, asymptomatic bacteriuria, which basically means that bacteria was seen and grown, and it's just really hanging out there. It's really not causing any symptoms. So especially as we get older, paying attention to symptoms is such an important factor and not just testing alone. And therefore, the presence of bacteria must be accompanied by symptoms, whether local or systemic. And then the workup with urology is really recommended. Sort of it's a one-off, you can manage it locally. But if you really want, specific specialty workup, that's recommended when there's been 3 or more infections in a 12-month span to evaluate for any underlying issues. And for risk factors, just hygiene, sexual intimacy, low fluid intake, long intervals between urination, and aging. I'm just rushing through the slide because simply prevention strategies are response to the risk factors. With hygiene, we just think about cleanliness after going to the bathroom. With sexual intimacy, there's been some recommendations for urinating after any sexual intimacy activities, or some people even take prophylactic antibiotics like a single dose. Making sure you drink plenty of fluids, shortening the time span of when you urinate so that bladder doesn't really stretch out. And then for the specific aging populations, we consider estrogen, topical estrogen application, where it can really change the flora, the acidity of the vaginal tract and the surrounding structure, so the urethra, and that can help with reducing infections. And then also for the aging, because the symptoms are less clear and there's often more of this asymptomatic bacteria, just making sure that there's a clear plan of when to suspect and test. And then I just want to list out supplements as well. There's a lot of supplements advertised out there, and studies after studies have shown that there's nothing that's really a slam dunk. They have very mixed results, where actually in comparison to good fluid intake, drinking 2 to 2.5 liters and making sure you don't stretch out your bladder can reduce the risk of infections. For fluid intake, it's about flushing the bacteria out. Same thing with making sure you go every 2 or 3 hours. But additionally too is that word I mentioned earlier, dysfunctional elimination syndrome. When that bladder is allowed because of holding urine for long periods of time, that bladder gets really stretched out. And when that bladder is really stretched out, the blood supply going to the bladder gets cut off. So your ability to fight off infection really decreases. The immune system just can't get to this bacteria that's misbehaving. And then the other part is chronic pelvic pain, the occurrence of persistent or recurrent episodic pelvic pain absent of infection. Chronic pelvic pain can go by many names depending on how different physicians think about the symptoms and its manifestation in the population. One of the very old ones is called interstitial cystitis that is still used today. It was coined in 1876. So this term has been around for over nearly 150 years. But then there's other terms like bladder pain syndrome in men, chronic prostatitis, chronic pelvic pain syndrome, and pelvic floor dysfunction. This chronic pelvic pain is a very nuanced, likely need for multidisciplinary evaluation, where often when there's pain that is of a chronic nature, there may be different factors that need to be addressed. And often going to just one specialist to solve all the symptoms is, I would say, is just a little bit rare, where we just need to look at different aspects of what might be causing the pain. So in the second bullet point of referring to urology is that our role in this multidisciplinary approach is that we want to know and navigate possible association of pain as it relates to lower urinary tract function. Is how the bladder fills and empty, is that precipitating the pain? And then so therefore management is really dependent on this multidisciplinary approach. What is discovered, what is determined. And often with pain, there's a bit of trial and error. So that part can be a little bit frustrating, where the initial trial might not do much. And gradually with time, as we understand more and test more and really work together in this team, we'll be able to help out more and hopefully get better outcomes of people who have their pain symptoms resolved. And then just a quick word on pelvic floor physical therapy is that there is a very important place. The indications for pelvic floor physical therapy is that, one, it's very safe, but certainly if there's a constellation of pain symptoms, especially the relating structures being close together, the bladder, vaginal tract, and rectum, when there's pain of all three with urination, bowel movements, and sexual intimacy, pelvic floor physical therapy can be very helpful. And the examination, or if the examination reveals that we can reproduce the pain when we press on different pelvic floor muscles, and that's where the therapist would be very helpful for individuals. So the last couple slides here is that we think about how infections and pelvic pain are related, is that the symptoms can look very similar and change in similar ways with aging. Similar symptoms in your younger ages are sharp pain, burning sensation, frequent trips to the bathroom, and small urinations. And then as we age, the symptoms can similarly change to pressure, abdominal or low back discomfort, more general changes to the lower urinary symptoms. Sometimes people have falls or fatigue due to the manifestation of either. And finally, the tests also become less clear with aging. The urinary tests may show inflammation and maybe some bacteria for both. It could be an infection, it might not be an infection. The imaging may show anatomic changes associated with aging. That's very nonspecific. And the specialty tests might not actually match the symptoms, or we see something on the urodynamic study, but that's not quite where you're expressing. So we're not sure, is it related or is there something else that's underlying? And that's where that multidisciplinary approach sometimes is often very much needed. And so that's all to say, is that the diagnosis of both is quite complex and difficult. And strategies to differentiate these causes are clues that we can use. Just as my time's running a little bit short, I'll just go through these last two slides a little quicker, is that the story of diagnosis can recurrence, holding urine for long intervals of time, fluid intake, and pain in nearby structures. That there might be very slight nuanced differences. And then examination and testing of urine testing, the physical exam, urodynamic study when there's no infection, cystoscopy without infection, and ultrasound may also show very nuanced differences. So the key is that undergoing comprehensive evaluation, while making sure we get the story right and knowing what tests to order and making sure that we're very definitive about what we're trying to gather as many clues as possible to understand what's going on, is the key to helping help both people who suffer from recurrent urinary tract infections and chronic pelvic pain. And similarly with incontinence, there's just this re-emphasis of your goals as we think about medications, in-office treatment, and refers to other specialties. And this is just a summary slide as well too, but I'll just close it there just for our time. So that's our last section. And I do want to open up if there's any questions as well.
Thank you so much, Joel. We are now at the end of the session, so if you have any questions for Joel, feel free to enter them in the chat. We have a question regarding physical therapy. Would you be able to comment on physical therapy for any problems related to the urinary tract?
Yeah, let me pull that slide up. So pelvic floor physical therapy for the lower urinary tract is that we see that often the muscles, some of the symptoms that are being manifested are truly the muscles itself. So the nearby, because everything is so close together, the muscles themselves, as they help control for example, incontinence symptoms to help you stay dry, can be exercised or stretched. Different core muscles can be strengthened to really optimize the way in which you're able to engage the pelvic floor. And so that's why the pelvic floor physical therapy can often be sometimes really, really helpful, where truly it is a more muscular issue. And by strengthening areas and stretching other areas, that can really resolve pain symptoms, that can help you feel more confident when you have incontinence. And even times too, people who rush to the bathroom might feel like they have a semblance of more control or more warning. So there's a role in it. Certainly the other flip side is that sometimes if it's truly a bladder issue that has nothing to do with the pelvic floor, often people feel like, oh, I was promised all this and not much happened. It's just basically that the pelvic floor muscles may not have much to do with the symptoms that were being manifested.
Thank you. And does overweight contribute to incontinence?
Did you say overweight?
Yes.
Yes, yeah. We've seen that for some reason, whether, some people have theorized it is just extra abdominal pressure, especially as we think about the resistance as how the bladder empties itself. But it's very theoretical. But we have just seen population studies, meaning that we've just analyzed, we've had surveys both in the United States and in Europe. We've just done large populations reporting incontinence, and we just found a positive correlation that people who have a higher weight compared to what is expected will manifest incontinence more often, and therefore exercise, why diet and exercise becomes so important. And it's not even just the weight, because reducing the weight will help, but also these activities of exercising regularly, somehow people do report that symptoms do get better. It's a good question.
Thank you. Early in presentation, you talked about limiting our caffeine, specifically coffee, no more than 1 to 2 drinks. How about decaf coffee? Is there same limits or anything in particular that you recommend?
Yeah, amazing question. That comes up often in our visits. Of just saying, well, coffee has caffeine, and we know caffeine makes me urinate more, but we just realized too that it's something about the coffee bean. Essentially, if you're drinking something that makes your kidneys work harder and pull water from your body and dump it to your bladder, not only do you need to replace the fluid to get, to where you were, but then to actually get a drink, you need another drink as well to get above that as well. So it's not just about caffeine, but something about the bean, something about the tea leaf and the alcohol molecule that we know can stimulate increased urine production by the kidneys.
Thank you. Then could you repeat where you discussed topical estrogen and where that would be applied?
Oh, very good. So yeah, that was a very, let me just put here. So this was a slide where I brought it up, and sort of that's one of the things I listed it just because it's very common. It's a very common recommendation. So should this be a conversation that you have with your general practitioner or a specialist like a gynecologist or urologist? Sometimes this is recommended. And essentially you just put a little fingertip, especially when related to the urinary symptoms. I think if it was related to vaginal dryness or atrophy, then there'd be a different recommendation. But for urology, what you do is that you put a fingertip amount, and then you just know where, sort of knowing your own anatomy is very key. And you just apply a small amount and just sort of apply it to that area. And again, it's originally, there were some older ideas that, oh, this will just make that tissue more nourished and healthier. But we realized that it's actually the estrogen affecting the acidity, and specifically related with urinary tract infections, that the more acidic that area, the less likely the bacteria, especially the bad bacteria that cause infections, will thrive.
Thank you. And while we're on this topic, we have a couple more questions about urinary tract infections.
Yeah.
Does cranberry juice help to prevent urinary tract infections?
Oh, nice. This is also a really good, a very good question to bring up, because this is a common question that comes up as well too, is that the original thought is that because what I just said about the acidity of the area, the urethra, by applying estrogen, it was thought, postulated the same way that what if we just made the bladder environment more acidic by drinking loads and loads of cranberry juice? I think part of the issue is that although theoretically that's a really great idea, what happens is that our body, for the fluids to get from here, from our mouth down to our bladder, it needs to cross through our stomach, it has to go through our bloodstream, and then end up in the bladder. And so our body, when things start getting a little bit acidic or too acidic, then what happens is that, and just neutralizes that acidity. So for you to make the bladder more acidic, just even slightly, you need to drink buckets and buckets of cranberry juice, which would not be sustainable. So what we do like about cranberry juice, especially the non-sugar ones, where it's just cranberry juice and can be a little bit bitter. I mean, for myself, it's quite bitter, but it's actually the fact that cranberry juice would be considered as good hydration. So outside of the coffee, tea, alcohol comment I made earlier, that would be part of the 64-80 ounces. So if you're drinking 2 liters of cranberry juice, that will definitely help reduce the risk of urinary tract infection.
How about cranberry pills?
Yep, and similarly too, this cranberry pills is a little bit more debatable. This is the supplements that we've talked about, where it's just this part of acidifying the urine. And there's a lot of products out there that really don't do much, just some generic cranberry extract isolate. But there's a specific one, why I say supplements have mixed results, is that there's this specific subtype cranberry supplement that you can buy over the counter called Allura. That's spelled Ellura. Specifically, this supplement or supplements that contain this have shown, some studies have shown that it's reduced recurrence of infections. Other studies have shown it hasn't really done much from just drinking plenty of fluid. So we say, we know, it's certainly okay to try, but just a generic cranberry, like concentrated extract, probably would not be helpful for you.
Thank you. How about for individuals who've had 2 to 3 UTIs in the last year? They don't seem to clear up after 5 days of antibiotics. Would anything else help, such as increasing it to 7 days of antibiotics?
Yeah, that's the excellent question about the length of antibiotics. Is that, from the guidelines and from our standards of knowing antibiotics, we really do know that different regimens, especially 5 or 7 days, really is adequate treatment for the urinary tract infection. But it goes back to that initial part about this part here, that the bladder is not a sterile environment, is that there's just this idea that we have the command of bacteria by just taking an antibiotic to wipe out the whole environment. Some people say, why don't I just take a stronger antibiotic? Just another add-on question of the length of the antibiotic regimen. And while certainly it can clear up the bacteria in the urine, it doesn't necessarily, it does not, frankly, just does not clear up the bacteria in the bladder wall. So the antibiotic regimen is certainly appropriate, and 5 or 7 days, you can certainly try it, and that will be a conversation with your provider of just saying, can I try a little longer course to see if I can get a longer, relief of symptoms. But if you're getting 3, especially once you hit that magic number of 3 per year, it might be something about the lower urinary tract function itself that is just putting the body more at risk for the bad bacteria that's hanging around the bladder to sort of repopulate and cause inflammation. And that's where that specialty evaluation with urology is a strong recommendation.
Thank you. We have a question regarding overactive bladder.
Oh, yes.
Are persistent constipation and/or stress considered factors for overactive bladder symptoms? In
Nice.
tracking their symptoms or patterns, they've noticed it tends to worsen during stressful times.
Yes, nice. There's 2 parts to that. One, I think just the 2 components of stress and constipation. For stress, there has been a positive correlation showing that stress certainly can worsen urinary symptoms. So overactive bladder, just for everybody else, overactive bladder simply just means urgency with frequency, or vice versa. The terminology has slightly changed, but essentially it's some combination of going to the bathroom a lot, way more than, sometimes more than a couple times an hour, and then also the rushing to the bathroom. So that's the definition of overactive bladder. We see that stress, especially if that's the underlying symptom, stress can worsen that. So we see that part. Constipation, on the other hand, is actually a different pathway. where historically it was thought that, oh, I have a very full rectal vault that's just pushing against the bladder. Just all the structures are closed, so I'm not moving the bowel, so it must be just really putting pressure. But actually, because of how elastic our structures are, the amount of space constipation the bowels themselves, the stool takes up, doesn't really cause that pressure. But when the bowels are really struggling, it itself has its own complex neural pathway where it sends to the brain saying, I'm struggling. The brain will say, well, try this or try that. And then the crossing point on the spine that where the brain communicates to the bladder and the brain communicates to the bowels, they're really close to each other. So if one is struggling, it talks to the other. It's called GI-GU crosstalk, and they affect each other. So why in urology we might be very interested in constipation is that if you're struggling emptying your bowels, then there's a very high chance that you might be struggling with empty your bladder. And that's actually the opposite of overactive bladder, where it's not just the frequency and urgency, but maybe it's the bladder itself is just so struggling so much and being able to empty itself more fully or adequately.
Yeah. I think we're going to circle back to UTIs. If you've had a UTI, as the lab test has shown, but symptoms go away after taking antibiotics on the first day, do you need to continue to take antibiotics?
Great question as well too. The answer is ideally yes. Simply, sometimes I think the part that can be a little bit perplexing is that sometimes the lab tests don't show anything, and then you're like, well, I took antibiotics and it felt better, so what should I do here? And that I'd say that's a much more nuanced part because we think about the lower urinary tract function. But specifically, if the urine tests show that there's bacteria and the symptoms really are suspicious for a urinary tract infection, we do recommend taking that course that has been prescribed. Certainly, the thoughtfulness and length is about making sure we adequately treat the bacteria that's there, because too low of a course sometimes promotes what's called resistance, where we just give just enough of a low dose hit to take away some of the symptoms, but not clearing enough in the urine so that whichever bacteria have survived this initial couple doses now have figured out ways, just they're single cell organisms that can mutate easily, can figure out how to resist the antibiotics and survive should that antibiotic be given again. And so studies have shown that this 5 or 7 day course typically is really the minimum course needed to make sure we adequately treat what's going on.
Thank you. I think we have time for one more question. Are you able to explain any similarities or differences between UTI and bladder cancer symptoms and how specialists can diagnose bladder cancer earlier on?
So one of the great questions. So bladder cancer can be actually very silent, where urinary tract infections, when there's bleeding associated with it, there should be usually other symptoms associated with it. If it's painless and you just see bleeding, that does raise suspicion that we need to look further. I mean, certainly other things can cause bleeding without pain. Just for example, a kidney stone that's moving around in the upper urinary tract may cause some bleeding with urination. But because bladder cancer specifically does not have a series of symptoms associated with it to say, oh, if you have this symptom outside of bleeding, then that should also raise suspicion, is that bleeding itself tells us that we need to do a workup. And so there's a urine test where we can screen for the cells to see if there's any risk of high-grade disease, but also that cystoscopy that I mentioned earlier, where we use the camera to look inside the anatomy, to look for any abnormal, we say lesions, but basically any abnormal spots in the bladder that say this does not look like normal tissue. That cystoscopy is very important to evaluate, especially when there's this first bout of bleeding without any other symptoms. And then finally, too, there's just an imaging test. Because I mentioned kidney stones, there's a specific type of CT scan called the CT urogram. That's just CT of the abdomen and pelvis, where first they do a scan without contrast, and then they add a little bit of IV contrast and do a second scan again, and just really see, is there anything that might have contributed to the bleeding? So those are the 3 tests that should, especially with the first bout, when you have not undergone any testing, where concern for bladder cancer would be part of the workup.
Thank you so much. Before we end today's session, do you have any final thoughts you'd like to share with the audience, Joel?
Yeah, just certainly, I kind of lost my place on the slide part, but so sorry I'm scrolling through here. But I just want to first say thank you for your time and just joining us today. But also, for anyone who does have bothersome symptoms, this is a plug for our team. Like, definitely please join our team. We're based out of Boston, Waltham, and Danvers, and our team is right now comprised of the physician I work under. His name's Dr. Pablo Gomery, a nurse practitioner colleague, Suzanne Roth, and myself. And once you get a referral, you can just call our main number here. You just type in MGH Urology should you miss the number, but call our main number and just ask to connect with us, and we'll gladly see you and just sort of really think about your specific story as well and how we can help.
Wonderful. Thank you so much, Joel, for spending the hour with us.
Absolutely. No, thank you. Thank you all.
And for everyone who joined us today, thank you so much. Hopefully you found today's session helpful. As I had mentioned, today's session is being recorded. If you're interested in viewing the recording, it'll be made available on the Blum Center website within a few weeks at massgeneral.org/Blum-Center. Thank you so much, everyone. Have a lovely rest of the day.
Take care.